I'm introducing the next speaker, Dr. Libby Lanford, who is one of our senior echocardiography attendings, and she's going to be talking to us about the postnatal echo imaging for patients with a univentricular heart.
Good morning. Wanted to thank the speakers for allowing me to talk about two of my favorite subjects together, echo and functionally univentricular heart. Bob, please forgive me. I'm going to use the word univentricular because this talk's going to go too long anyway. I can't get the whole sentence in. I'm going to steal from Bill. This is going to be a whirlwind survey of echo images of some classical single ventricles and hopefully a few helpful tips along the way. So starting with the most classic and the most common that we see is hypoplastic left heart syndrome. And you can see that there is a patent mitral valve with good leaflet, some leaflet movement, a very hypertrophied echo bright hypoplastic LV, suggestive of EFE, and a dominant RV. You can see that the LV is not apex forming. When we tip up into the LV outflow tract, we see the LV cavity, you see the ascending aorta here, but we were never able to identify any aortic valve leaflets. You can see that there is sort of a wall between the LV cavity and the ascending aorta. Moving on to a parasternal long axis view, which is very helpful in many of these hearts. Again, you can see the LA patent mitral valve, LV cavity, ascending aorta, again, no visible connection between the LV and the ascending aorta. LV again is posterior, not apex forming, and then a dominant right ventricle. Again, just another quick look, a parasternal short axis sweep down to the LV apex. You can see here is the hypoplastic LV, echo bright, EFE, dominant RV wrapping around. As has been mentioned, this is the lesion where we worry about coronary artery fistulas. And so here, going back to that initial apical four-chamber view with color flow on the myocardium, you can see multiple color jets consistent with coronary artery fistulas. This child actually went on to have a Norwood and had really no ischemic complications. One of the tricks I always like to teach our fellows is that in many of these patients, the ascending aorta is incredibly hypoplastic, and so it's very hard to find the arch view. So my favorite view is the high parasternal, where you find the MPA and the RPA. The little black dot next to the MPA will be your ascending aorta. Typically your dot of the probe is about 3 o'clock. You rotate on it, and hopefully you'll get a picture that looks like this. And you can see this severely hypoplastic ascending aorta, transverse, and a large ductal ampulla. Moving on to another variation of hypoplastic left heart syndrome. And I think this might be one that Dr. Weinberg may have shown. Starting in the apical four-chamber view, you can see it's easier to see on the color at first. You see two pulmonary veins coming in. So here is the left atrium. You see an ASD with a lot of flow going across. But if you look down below where that left atrium is, you see the bar. You don't see any mitral valve. And I think that this is similar to the example that Diane showed, because if you look, you'd expect an LV to be here. I don't see any abnormal thickening here to suggest a hypoplastic LV chamber. Again, doing our parasternal long axis view, which is very hard to do when you have no septum, but this is actually lined up correctly because here's your hypoplastic, very hypoplastic. I think this was like 1.5 millimeters. Ascending aorta, tricuspid valve, RV, pulmonary valve, no sign of an LV. So when you're hunting for another ventricle, you need to sweep entirely through the heart. So you want to go from all the way anterior to all the way posterior. So on this baby, there's a sweep from the pulmonary valve all the way down, and never do I see, I'll let it play again, sort of you want to look at the wall to see if there's any little thickened portion. I never saw anything that I would recognize as an LV. So this is sort of a classic mitral and aortic atresia. Just to show the different variations we can see, This again is this was the mitral aortic atresia that we saw. This was the mitral stenosis aortic atresia that we saw. I'm going to try to use the right phrase. This was a hypoplastic left heart complex, which is mitral stenosis and aortic stenosis. And actually, it's kind of an interesting one because you can see that there is a patent mitral valve, but it's fairly abnormal. It was borderline in size. LV is mildly hypoplastic, not quite apex forming. And we actually were hopeful that this might be biventricular, but unfortunately did not do well with hybrid physiology, and actually has gone down a single ventricular, univentricular pathway. And then an example of an unbalanced AVSD, where you can see an ASD primum, a common AV valve, atrial septum lines up with a ventricular septum, and there's a very small portion directed to the LV cavity, and with color flow, it was minimal flow entering that LV. Moving on to some other versions of univentricular hearts. Here is an example of a tricuspid atresia, an LA, mitral valve, mildly dilated LV. There's a sense here, I'm sorry, I know this is a little dark, of the septum here and a small cavity over here on the right. When we tip up a little bit into the LV outflow tract, you see this small VSD and a hypoplastic right ventricular chamber. I like this view when you're looking at a hypoplastic anterior chamber. This is actually an apical 3-chamber view. I'm sorry, it's a little bit off axis, so it's mitral valve, LV aortic valve, nice continuity between the mitral and the aortic valve. And you see this small VSD in this little anterior right ventricular chamber. And looking with short axis, this is really all there is of a right ventricle in this patient. Here's the VSD, right ventricular outflow tract, and the pulmonary valve. Again, just to briefly point out that for many of our functionally univentricular hearts, you have to have a good sized atrial communication because you have to have a way to get both systemic and pulmonary venous return to the dominant ventricle. So here, this is just showing you a large ASD with unobstructed right to left atrial shunt. Again, we were sort of worried about that VSD, and this is normally related, so we'd worry about pulmonary blood flow. So here's a view of the aortic arch. It's probably hard to see, but there is a small reverse-oriented duct, which makes you think of limited pulmonary blood flow in utero. And there was a hypoplastic pulmonary valve. So this child actually went on to have a BTT shunt. Looking at another variation of tricuspid atresia, again, LV, mitral valve, LV, but in this case, we already can see the hypoplastic right ventricular chamber. Again, I'd like to point out the atrial septum is bowing into the left atrium from the right to left atrial shunt. Looking at a short axis, we can see the LV. And what I liked about this one, that this is clearly a mitral valve, so we know we're dealing with an LV. And then we want to look at the great vessels. There's one large one, one small one. Hopefully I can convince you that this is the PA. It's diving posteriorly, it's bifurcating, and this thread bouncing around the LA is actually, again, the atrial septum that's being pushed over because of the right to left atrial shunt. So when you have two discrepant great vessels, then you can certainly go, what I like to do is go look at the arch. So the arch is small, then the small one is the aorta. In this case, the aortic arch is very hypoplastic and tortuous. It's easier to see with color. Here's the arch as we go around, hypoplastic transverse, severe coarc, large duct. So the PDA here is supplying systemic output. So again, in transposed great vessels and tricuspid atresia, you would expect arch issues. Moving on to a different example of a hypoplastic right heart. See the LA, mitral valve, LV. See this small RV with marked hypertrophy and what looks like a moving tricuspid valve leaflets. So just to prove that it is actually a patent tricuspid valve and not imperforate, we see that there is a small anterograde jet in diastole across the tricuspid valve. And then we look in short axis. Here is your LV, and here is your hypoplastic RV anteriorly and rightward. So now we want to go looking for a pulmonary valve, and this is what was measured as the pulmonary valve. I know it's a little fuzzy. It's actually a blown up parasternal short axis view. So here is the aortic valve, here is the LA, the RA is over here, and here was tissue bouncing back and forth that we thought was a pulmonary valve. However, when we put color on that area, what we see is two-fro flow. And when you Doppler it, what you see is the two-fro flow of a left atrial appendage. And this is unfortunately, easy mistake to make, or at least I've made it twice, and I actually did not read this one, and the person read this also. So what you're actually looking at here is the tip of the left atrial appendage with a little bit of fluid around it. It's also, you can see it here more clearly, that it was easier to see the tip of the left atrial appendage here. But because we always go looking for a pulmonary valve here, that's where the appendage lives. So, and you can get fooled because we don't expect antegrade flow. And because this child has pulmonary atresia, we need a duct to supply blood flow to the branch pulmonary artery. So here's a large duct feeding good-sized branch pulmonary arteries. Moving on to double inlet left ventricle. This one will be a classical one. It actually is interesting. In our database, we have more Holmes hearts than the classical double inlet left ventricle in the last 10 years. So that's why these pictures are a little bit fuzzy and old. So two AV valves draining into one large ventricle. I like this view because this is a short axis of the two AV valves. I was taught to refer to the AV valves as right-sided and left-sided because they don't have necessarily the typical appearance. But in this case, this posterior AV valve certainly looks like a mitral valve to me, and the anterior one looks like a tricuspid valve. When we go to our parasternal long axis view, sorry, my mouse is unhappy with me. There we go. Parasternal long axis view, you see this VSD and this anterior ventricle. We can't tell yet which semilunar valve this is. We tipped up into the anterior right vessel here, which is hypoplastic. It doesn't bifurcate, so this is the aorta. So this is the aorta coming off of the hypoplastic RV chamber, and we can see the small VSD here. So this is discordant VA connections. I'm just going to let this play once so you can see large pulmonary valve, small anterior aortic valve. And so I took snapshots to sort of point this out. So posteriorly, here we have the pulmonary valve. We sweep a little more anteriorly. I know it's hard to see, but that is your aortic valve. And you're starting to get into the VSD. Here I've frozen it just because I think this is a helpful view, for at least for me, for pattern recognition. Here is the bar of the septum. It typically in the double inlet left ventricles has this horizontal course. Here's the VSD. And if we go all the way anteriorly, and again, you will not see this chamber unless you sweep all the way anteriorly till you've essentially lost the heart. You can see here is the septum. So here you can clearly see the more inferior LV and then the more anteriorly, superiorly anterior RV, which we classically see in double inlet. And just to verify, given that we had a small VSD and small aortic valve, again, severely hypoplastic aortic arch, ductal dependent for systemic blood flow. Moving on to another type of double inlet left ventricle. Again, in this view, they look fairly similar. I neglected to mention both examples that I'm showing have two good-sized AV valves. This is the one exception to the rule where you don't necessarily need an ASD as long as neither of the AV valves are obstructed, because both systemic venous return will go to the LV and pulmonary venous return will go to the LV. But when you go to the short axis view, you get a completely normal looking short axis view. So this is your aortic valve, this is your pulmonary valve. If you look, there even a suggestion by 2D of coronaries. Both semilunar valves are good size. This anterior one bifurcates, so that's a PA. The only thing that's missing is the tricuspid valve, and this is where it should sit in a normal heart. So again, to show you this one, as a sweep, this sweep starts right below the aortic valve, so this would be your anterior RV, and as you watch, this anterior AV valve has attachments to the crest of the septum, and as we watch it come all the way down, sometimes it's hard to tell whether you're dealing with a papillary muscle in these dominant ventricles versus a septum. So what I do is I want to follow it to see if it ever completes the wall. And so in this case, I'll let that play again. You can see that this bar comes all the way across and shows you this is your LV, this is your anterior RV. But as you watch, this AV valve is 100, there are no attachments to the RV at all. So this would be a double inlet left ventricle, normally related great vessels, otherwise known as a Holmes heart. Okay. And as expected, this child actually had good-sized aorta. The aortic valve was good-sized and good-sized PAs. This was done on the first day of life, which is why there was still a duct. When the duct closed, after a couple of weeks, the infant was over-circulated and actually got a PA band. And then this is one last one quickly. I believe that Dr. Weinberg showed this one for her unbalanced AVSD. It looks like the same pictures that I've been looking at. So here is the apical four-chamber view. Just so that people don't confuse, this is a very dilated coronary sinus because there's a left SVC. You can see the atrial septum and see what looks like an ASD primum, which is why we think that this is an unbalanced AVSD. You see ventricular wall as we go all the way around. But there's a little bit of extra stuff here. Again, when you're looking for two AV valves, two semilunar valves, two ventricles, you want to make sure you do a sweep all the way from posterior to anterior. You want to start before the heart and end before the heart. And so as we watch, we're only going to see one AV valve. And then as we watch over here, you'll see a large semilunar valve, which is the pulmonary valve, and then you'll see a hypoplastic ascending aorta. Again, short axis view looks very similar to what we actually saw with the mitral and aortic atresia. No obvious other ventricle, a very hypoplastic ascending aorta. And then the short axis view, since us imagers frequently will use the AV valve to determine a ventricle. We had some discussion about this. I've looked at it multiple times. It doesn't look to me like a tricuspid valve. It doesn't look to me like a mitral valve. It looks most like an AVSD, but still it's sort of got four leaflets. So it doesn't really look like an AVSD to me either. But that's also, the AV valves frequently are not that easily identifiable once you're in the univentricular heart. And just for clarification, this is the left SVC coming down and around and entering the coronary sinus. This is an extra tissue over there. And to be expected, this showed a hypoplastic arch. I think that this is the same heart that Dr. Weinberg showed with the red flow going backwards in utero. We were using the same database. So ultimately, I diagnosed this. I did actually read the first ex utero echo, right dominant, unbalanced AVSD, mostly because of that primum ASD, double outlet, right ventricle with aortic atresia. We only had one recognizable ventricle, although I think that there's that tissue that we can see in that four-chamber view. Hypoplastic aortic arch. I didn't show you, but this infant also has bilateral SVCs, ipsilateral pulmonary veins. I actually forgot to put in the interrupted IVC, and so this child classified as left atrial isomerism, and I believe that the next speaker is going to show some additional imaging that we obtained. Thank you.